Welcome to Alzheimer's Sunrise, lighting the way for patients and caregivers on Legends 100.3, brought to you by Alzheimer's Community Care, providing help and hope for thousands of families for the past 20 years. Here's Mary Barnes, CEO of Alzheimer's Community Care.
Welcome to Alzheimer's Sunrise, shining a light on patients and caregivers on Legends Radio 100.3 FM. You can call us at Alzheimer's Community Care at 561-683-2700. You can also send us questions or comments by email to info@alzcare.org. That's ALZCARE.org. And it's also our website, again, alzcare.org. If you call us, if you send us an email, please tell us you heard about us on Legends Radio. And I'm here this morning with our president and CEO, Mary Barnes. Good morning, Mary.
Good morning. Another special show that we're doing, and we've got a very interesting guest. One of our, how shall I say, budding medical stars that
Yes.
we expect a lot of future notice on in medical journals and discoveries. And why don't we talk and you introduce her and say
Absolutely.
the different parts about her exciting young budding life.
Alexandria Watkins came to us back early last fall. Alexandria is in the Doctor of Nursing Practice program at Palm Beach Atlantic, so we are going through this program together. We're both about midway through. And when the students come to us, and we are just thrilled and blessed to be working with so many students. We have doctoral students. We have students earning their Master of Science in Nursing degree. We have nurses earning a bachelor's degree. We teach certified nursing assistants. So we're thrilled to be working with so many students. But
I just want to interrupt
Mm-hmm.
with Karen.
Sure.
She's very modest and she doesn't talk too much about how she believes in acquiring this kind of expertise within the medical community, and how you have been such an inspiration, Karen, yourself, just you yourself.
Thank you.
Yes.
And having other students and having this opportunity. And, we've always had a wonderful, as an organization, relationship with Palm Beach Atlantic University. It's always been very special. But going down this road and having this pathway for our future medical providers, this is really exciting. And coming from my perspective, and with our organization being in its existence, to see this other type of dynamics where it has a legacy. That's because of you, Karen. And I've got to tell you, it's part of our legacy. We've got other legacies as well, but this is just as important as
Well, you have
others.
made this a priority as well, and it is incredibly important. And as a team, we get to make this happen. But all of the students, those students who are already nurses, who are earning a more advanced degree, they have to focus on specific projects. And many of them pick a project that's in our realm. We've had students studying Lewy body disease. We've had students studying the effect of polypharmacy, which is 4 or more prescription medications on a patient that has Alzheimer's or related disorder. We've had students focus on the risk of falls, which is incredibly important for these patients. And Alexandria, I want to talk to you about what you focused on. Now, you came to us from Texas, having your first 5 years in nursing, actually in oncology.
Yes.
In neuro-oncology. Tell us a little bit about the type of patients you worked with.
So that was an interesting field to work in. Most of the patients that came in, they initially started off saying, I was having a little bit difficulty sleeping, or I was forgetting certain things. And then one day I would have difficulty typing out a sentence on my laptop. The common theme also with these patients is they would tell me, I just figured this was a normal part of aging. This was something that just takes place, so it never concerned me. Now, when it came to them not being able to type out a sentence on a keyboard, or most likely it intervened as a seizure, they would come to the hospital, we would do a brain scan, and unfortunately we would deliver the news that they have a brain tumor. And I found it interesting at that time as a naive nurse. I thought, oh my goodness, this just comes on so suddenly. What a scary thing. But as I started interviewing patients, I started realizing that first of all, we don't do any brain screening to educate patients that these are not normal aging symptoms that happen. So we're doing a disservice to our patients by not educating them on that and letting this type of disease progress because they're just uneducated. And then I found it interesting that once they were getting treated, we never did any cognitive screening throughout the treatment and after the treatment while they were receiving the chemotherapy in the hospital. And so there would be times where, you don't normally see this in regular care, where a patient would be able to speak to you during the morning time, and then at afternoon they totally lose all function to speak. These are the type of things that these brain tumors were causing for these patients. At that time, though, we were not, we were saying, oh, this is, once again, normal for the disease process. But we never created a baseline for this patient, so we don't know how normal it was for that disease process or how abnormal it was. So once again, it goes into, we just don't think about the brain, and we don't think about getting baseline understanding of the brain.
That's right, and you've hit on something incredibly important. And we'll be back to that thought in just a moment. This is Alzheimer's Sunrise, shining a light on patients and caregivers on Legends Radio 100.3 FM. You can call us at Alzheimer's Community Care at 561-683-2700. You can also send a question or comment by email to info@alzcare.org, ALZCARE.org. If you call, if you email, please tell us you heard us on Legends Radio. Now, one of the concepts you just addressed is the fact that we don't routinely talk about brain health. Mm-hmm. We may go to the physician every year and get what we call an annual physical, mm-hmm. and they check your blood pressure and listen to your heart, and they ask you if you're a woman, did you have your mammogram? Did you get your skin check? Of course, always a big concern here in Florida with our sun exposure. If you're over 50, did you have your colonoscopy? Mm-hmm. They'll ask all of those questions, but how often does someone ask about the brain? And a few months ago, you actually interviewed quite a few patients in that regard. Tell us about that.
Yeah, and interestingly enough, I had hypothesized that, the majority of my patients would say that, first of all, they don't think about their brain health, and second of all, they have not had it discussed with them at their primary care visits. And so in an outpatient setting, GI setting, so where we do secondary preventions such as colonoscopies and things of that nature, I screened 105 patients. Now, out of these patients, 59 of them were 65 years or older. This is important to mention because they are beneficiaries of Medicare at this point in time in their health care. Now, Medicare does require a part of their annual wellness check to have a cognitive screen. And so these patients should be aware that they were screened for their cognition, or they should have an understanding of their cognitive baseline. Now, out of these 59 patients, there were only 8 that reported ever remember having a cognitive screen, or they remember the screen being done. And I say that because, sometimes patients can be screened and not know it, and that's just as important as not being screened, because if you don't know you're being screened, you can't do anything about it.
So the doctor might be asking some questions, or the nurse practitioner that he or she thinks would demonstrate whether they have any impairment.
Correct.
The patient wasn't even aware that anything was done.
Correct. So you could see how that could be a problem. So of these 8, none of them reported being screened with the same screening tool. Which is also a problem because as medicine is so specialized now, and as you maneuver through the healthcare field, if you are not using the same tool, who's going to understand that language?
That's
so
right. Who understands the measure?
Yeah, it's more likely to fall in the cracks, per se. The other interesting thing to note is out of all 105 patients, I believe my youngest patient was 19 years old and my oldest was 97. So out of all of those patients, there were only 4 patients that recalled actually sitting down and having a conversation about brain health with their primary care provider.
And it's so simple. There are so many things that we now know we can do. We call them at Alzheimer's Community Care risk-reducing lifestyles. Mm-hmm. But I will say that some of our researchers right here in Palm Beach County believe that these lifestyle choices can be preventive. Yeah. And they're talking about getting enough quality sleep,
yes.
What we call rapid eye movement sleep when you dream, not smoking. eating a Mediterranean diet. In other words, minimizing foods that are inflammatory, because inflammation is believed to be the root cause of many diseases, cancers, as you mentioned,
Yes.
heart disease, diabetes, and a risk factor for Alzheimer's. We talk about continuing to learn new things, staying socially active. These are very important lifestyle choices, getting enough exercise that people can do. But if no one's talking to you about it, you don't understand the importance. And even if you mentioned that the Medicare program has permitted physicians, or actually required, that they incorporate cognitive screening into that annual wellness visit.
Correct.
But they didn't give any instructions. They
That's
didn't
correct.
say which tool to use. They didn't say how to measure cognition. So as you said, if we don't have a standard, how do we know the quality of that assessment that the physician or practitioner is making? We don't know. And that's one of the things we're actually advocating for, and so thrilled we were invited to address the Baptist
Yes.
Health Conference on June 15th with over 100 health professionals in the room, because we really want everybody to start thinking critically about A, are they evaluating cognition on any routine basis? And B, should they be doing it with some kind of a standard? Now, let's take this a little further. Even if those 59 patients over 65 had been screened, is that the time we should begin screening? Is 65 years of age really when we should begin? And we'll come back to that thought in just a moment and develop that a little bit more. This is Alzheimer's Sunrise, shining a light on patients and caregivers on Legends Radio 100.3 FM. We invite you to visit our website at alzcare.org, alzcare.org. You can also send us an email with questions or comments to info@alzcare.org. You can call us at 561-683-2700. So I know you're passionate about this, about the need for routine screening, about the need to do it in a standard way. So what would you say about that? Should we be waiting till 65 to start screening brain function?
Well, I'll turn the question back on you. Should we wait till 65 to start checking for hypertension?
I don't think anybody would feel comfortable with their blood pressure beginning to be checked at 65.
Correct. Or, the other common theme is diabetes. Would you feel comfortable with a doctor waiting until you're 65 to start
No.
testing for
No,
diabetes?
because your blood sugar could have been creeping up and actually be high.
Yes.
And even if you're pre-diabetic, we now know that damage is going on in the vascular system.
Irreversible damage,
That's right.
we'll say.
And if we didn't screen, we didn't know. Nobody would accept that. Nobody would accept waiting to do mammograms or colonoscopies until 70, because we know, and we know from so many cancers, we know from cervical cancer and breast cancer and colon cancer and prostate cancer, that when they are identified early, patients do very, very well.
Correct.
The survival rates for these cancers have improved dramatically. I'm a nurse 43 years. It was far different 40 years ago. It was a very bleak picture. And so why are we not applying that same logic to the brain?
Well, I'll tell you, it's definitely going to have to be a culture shift. In the beginning of my career, I worked in an orthopedic clinic, and I was able to head up, it's called the Impact, and basically what we do, it's a computerized test, and all student athletes before school started would come in, take this test, and then afterwards, if they were to sustain a concussion during the year, we would have them come back in and take this test. If there was a variance in their score, that would tell us how long this person needed to stay off the field. Now, looking at it now, the only reason why we were performing this test is not for their brain health. We were doing it to say, okay, this is the earliest you can get back out on the field and get hit in the head again. Now, once again, as a naive nurse, it never dawned on me to think, what are we doing to this child's brain? And so I tell you that story to say that we need to start screening, at the age of 18, at least the age of 18, where, if a child has sustained a concussion, they need to have that yearly check with their physicals to make sure that their baseline is not slowly but surely
And they need
declining.
to rethink if they want to continue being exposed
Correct.
to that type of trauma. We see this now in young people, our returning servicemen and women.
Correct.
That are suffering head injury.
And we actually perform these tests on some servicemen and women that were suffering with.
So
cognitive
I will say, and you know this, whenever I'm in front of student nurses, I always start by telling them what we do at Alzheimer's Community Care, what our model of care is and what it accomplishes. And I ask how many of them are planning to work with seniors who may have Alzheimer's or related disorder. As you may expect, I don't get many hands.
Yes.
Most want to go to the emergency room or intensive care or the newborn nursery.
Yes.
Yes.
Those are the hot spots, and that's great. But I say to them, you must understand, you will encounter patients in all stages of life that may be manifesting cognitive impairment because of a sports injury, because of an auto accident with head injury, because of being hurt in combat, in military service, Down syndrome. We now know that unfortunately in the 40s, in the early 40s, a patient with Down syndrome can actually develop Alzheimer's pathology, the pathology of tau and amyloid protein. We know that those who inherit Huntington's disease will manifest by the 30s. So any rising health professional needs to understand that cognitive impairment can manifest really at any age, depending on what dynamics are going on. But we won't find it early. We won't see it if we don't screen.
Correct.
I want to just say something that I've just realized, and that the three of us have something in common, and we have all been recognized by the Palm Beach County Medical Society as heroes in medicine. So I'm very thrilled. Mary, I'm not sure which year yours was, 2012 or 13?
Probably 2013, because it was after we had passed the two legislative...
The Silver Alert
the Silver
and the-
Alert and the Specialized Alzheimer's Daycare Act.
All right.
So,
And those were
which-
two huge achievements for our vulnerable population.
And especially doing attention on the state level and getting the state to understand that they can do something.
Yes.
Something
not
can be
helpless.
done
That's right.
for
Yes.
people who are in trouble.
Yeah.
And I have to say, law enforcement was really, of course, at that time, Charlie Chris was the governor at that, and he did this executive order and sort of wrote up this outline and started the whole process. But we as an organization were the ones that really put the legislation in place.
Fabulous.
So, but having the Palm Beach County Medical Society has this wonderful, wonderful way of recognizing special types of significant endeavors. And I'm so proud that
And
you're
Alexandria was
getting one
recognized
of them.
this year,
Yep.
back in May, as a hero in medicine in the category of college students. And I was thrilled last year, a hero in medicine and education.
Yep.
So we're glad to see that those efforts are being recognized, because we do it on behalf of the greater population, of the
Yes.
people that we serve. We'll be
Yes.
back in just a moment. This is Alzheimer's Sunrise, shining a light on patients and caregivers on Legends Radio, 100.3 FM. You can call Alzheimer's Community Care at 561-683-2700, or send us an email with your questions or comments. info@alzcare.org, ALZCARE.org. So when we had the opportunity to present to over 100 nurses and healthcare executives for Baptist Health Systems, again, because they desperately wanted this presentation.
So what's the heart of this presentation?
Well, the heart of it was, again, making a case for why screening should be routine
Yes.
and done with a standard measure, as Alexandria said. We take blood pressure with FDA-approved equipment.
Right.
That wouldn't vary from setting to setting. The brand name may vary, but how that equipment is made is standard. So that when we give a blood pressure reading from one location to another, from the doctor's office to the hospital, or the hospital to the rehab, or the rehab to home health, everyone understands what those numbers mean. It's a standard.
But it's also built into another whole picture, a profile of that person.
That's right. It's
when
one
they're
of their
actually-
vital
right,
signs.
Exactly.
Exactly.
Yes.
We all take pulse the same
That's
way.
right.
We
That's
measure
right.
temperature in the and report it in the same way. And so what we're saying is cognition needs to be measured in a standard way as well. And there is a tool that the federal government mandates in rehabs and nursing homes. We want that tool to be used everywhere until a better one is discovered, and then we should all use that better one. So that when we report that score, every healthcare provider understands what it means and understands if that patient is impaired. Judging by that screening tool, we need to have special care plan interventions in place for their welfare, for their safety, and to really minimize the possibility of things going wrong in the hospital setting or after. So the other part of the presentation had to do with, we're not there yet. We don't have standard screening in doctors' offices or nurse practitioner practices. We're hoping to get there, but that will take a lot. It will take mandatory education for physicians and nurse practitioners who are out of school quite a long time. Right now, there is no mandatory continuing education.
And you would think that would be a no-brainer.
You would think, but we're not there yet. So until we get there, we want to help these hospital nurses and hospital executives understand how they can utilize a cognitive assessment tool, and they can care plan for that patient to reduce the risk that the patient will be there longer than they otherwise would be, and to reduce the risk that that patient will keep returning to the hospital. And we have a huge issue in South Florida because of our population, particularly Palm Beach, Broward, and Miami being such huge counties, with patients who are repeatedly returning to the hospital. It is, of course, a terrible blow to quality of life for them and for their caregivers. And with every hospitalization, more troublesome things happen. More medications get added. They experience falls. And often there's another dynamic called delirium that these patients are more susceptible to.
What about that delirium?
Well, it's missed up to 75% of the time in our hospitals.
I think the unfortunate thing is delirium in the hospital can sometimes be classified as altered mental status. The problem with that is altered mental status means nothing. Delirium does mean something because that tells you it is something that can be treated. Right. I'll give you an example. So when we were finished doing our chemotherapy for these brain tumors, unfortunately what happens is the patient's sodium levels will vary when we start giving drugs that cross the brain barrier. So we would transfer these patients either to an intermediate care unit or a medical surgical unit. Now the problem is, and I even hate admitting this because I was part of the problem, we would transfer and say they have altered mental status, and that's all we would tell the nurse taking the patient. Well, had we had a standard such as BIMS, I could have said this patient's BIMS was a 15 when they got here. It is now a 12, and they can go back and forth from a 12 to a 13. As I had mentioned earlier, the brain tumor can cause, from 1 hour to the next, you can communicate and not communicate. Now, when we sent them to, either a step-down unit or med-surg to get their sodium levels balanced out before they were sent home, the nurse then didn't know, they didn't have a score, so the patient would indeed decline, which was a natural process for the brain tumor, but because they didn't have that score or understanding and they thought, their altered mental status is getting worse, they would end up being sent to ICU, they didn't need the ICU. So that's where delirium, we need to call it delirium and not altered mental status.
Right, delirium is an acute onset of increased agitation or confusion.
Correct.
It could also be the opposite. They could suddenly become very withdrawn. This is where the family can be so helpful.
Yes.
Because the family can say, no, that's not how he usually is. This is a big change.
Yes.
And you mentioned the BIMS, which is the brief interview for mental status.
Yes.
It is a simple test that takes 2 to 3 minutes max to administer, but it delivers a score.
Yes.
And if that receiving nurse knew that the patient was impaired as measured on the BIMS, they'd already be thinking, okay, I need to know that he's at higher risk for delirium.
Yes.
Let me not call it altered mental status, which has no meaning. It's like saying other.
Yes.
We don't know what's wrong.
Yeah.
And then it drives a further evaluation by the nurse practitioner or the physician to get to the root cause of the delirium, which, as you so correctly stated, can be treated. And this is why it is so vital. We're fortunate. We keep our patients out of the hospital to a great degree by identifying illnesses early and getting them treated in the doctor's office. But when they do have to go into a hospital, we beg that the family try to be there as much as possible. We don't want those behaviors medicated. We want them recognized and properly addressed.
Is there not a expectation medically is when you know a patient that does have a form of neurocognitive disorder, that the expectation that they're going to have delirium?
No, not now, Mary. It's not
Don't-
recognized. That's the whole
No.
crux
That's
of
what I
this
mean.
presentation.
That's what I mean.
Yeah.
It should be
A principle.
It should be an expectation, and the family and the doctor when he's getting ready, because there are times that you have to have that person to go in the hospital for whatever reason. Maybe even they have a pacemaker and they have to change the pacemaker. I mean, there's lots
There
of
will be some unavoidable times.
inintrusive, not being able to just do a practice, but to have that background and have that part of the medical profile.
It should be part of the plan when they
it's
enter
a life-saving,
the hospital.
Yeah.
It's a life-saving, life-impacting.
So the scary thing is if you think about it, we were treating people with brain tumors, so we should be setting the standard because we have neurologists on the case, but we weren't even setting the standard there. So how do you expect a standard to be set when somebody's just coming in for hypertensive crisis? It has to start somewhere, and it wasn't even starting there. Is my point.
So we're putting it in the schools, and we're advocating for standard education, required continuing education in the health professions, and hopefully this will improve. But we're also educating those families to demand that type of attention.
Absolutely, because if the family doesn't have the right diagnosis, and I keep on hearing the word, well, my husband doesn't have Alzheimer's, or hear the voice that my husband doesn't have Alzheimer's, he has dementia. That's not quite.
It's still going on
It's
to
still-
a huge degree.
And so that's got to stop.
Dementia is not a diagnosis. It is not a disease. Do not accept that. Ask why
Yes,
do
right.
I or why does my loved one have symptoms of dementia? Because many are treatable. I'm afraid we have to wrap up for today.
Oh.
Alexandria Watkins, thank you
Thanks
so
well, thank
very
you,
much.
Karen and Mary, for allowing me to work with
Well,
Alzheimer's
we're-
Community Care, and both of you have enjoyed it.
We're proud of you.
Yes, we are.
We are proud of you of doing what you're doing, and we have high expectations for your future. So
Wonderful. I'll try to
You're a
meet 'em.
wonderful advocate. Thank you so much.
Thank you.
take care.
Thanks for listening to Alzheimer's Sunrise, lighting the way for patients and caregivers. To learn more about the help and hope available from Alzheimer's Community Care, call 561-683-2700 or visit alzcare.org. That's ALZcare.org. Tune in next Sunday at 6:30 for another edition of Alzheimer's Sunrise, lighting the way for patients and caregivers right here on Legends 100.3.